Hi, I am Supun, currently working as a doctor in orthopedic and trauma unit. Today we are going to discuss about chest X-ray interpretation. It doesn't matter whether you work in a medical or surgical load, but you have to involve in a chest X-ray interpretation in your day-to-day life. So let's get started. The interpretation usually starts with checking the patient details. You should confirm the patient name, date of birth, and unique identification number before starting interpretation. And then check the date and time the film was taken. Some patients may have several X-ray films. In that case, you will miss the X-ray with the significant findings. Then you have to assess the image quality. Here we use the RIBE method. First we need to check the rotation. To assess it, check the distance from the spinous process of the vertebra to the medial aspect of clavicle. Then you need to assess the inspiration. If you have X-ray with a good image quality, it will show 5-6 anterior ribs, lumbar apex, both costopenic angles and the lateral rib edges. Then you need to check the projection. Your X-ray can be either anteroposterior or posterior anterior. If there is no label, assume it's posterior anterior film. And in also posterior anterior films, you cannot see the scapular shadow. If your film has a good exposure, the vertebra should be visible behind the heart. Then we move to the ABCDE approach. Following this approach, you will not miss any pathologies. The ABCDE approach stands for the airway, breathing, cardiac, diaphragm, and everything else. In the airway, you have to check for the trachea, carina, bronchi, and the hilate structures. Usually the trachea is located in the center or slight deviation to the right. If you see something pulling the trachea to the either side, you have to check what is pushing or pulling the trachea. Large pleural effusions and tension pneumothorax push the trachea, and the consolidation with associated lower collapse will pull in the trachea. Rotation of the patient can give the appearance of apparent tracheal deviation. The hilum consists of main pulmonary vasculature and the main bronchi. Lymph nodes are not usually seen. The left hilum is often positioned slightly higher than the right, but there are variations. The size of hilum is usually the same, so the asymmetry should give rise to suspicion of pathology. In the breathing, you have to check for the lungs and the pleura. Divide the lung into 3 zones, each zone occupying the 1/3 of height of the lung. So you will not miss any pathologies here. But these zones do not equal to the lung lobes, as the left lung has 3 zones but only 2 lobes. Inspect all 3 zones for the lung markings. The complete absence of lung markings should raise suspicion of pneumothorax and increase radiopacity with suspicion of consolidation or malignant lesion. The pleura is not usually visible in healthy adults. If you see pleural thickening in the X-ray, it gives rise to a suspicion of mesothelioma. When you assess the cardiac shadow, you need to assess both the heart size and heart borders. In a healthy individual, the heart should not occupy more than 50% of the thoracic width, but this rule is only applied for the PA chest X-rays. The AP chest X-rays exaggerate the heart size. In a healthy patient, the border of the heart should be well defined. In pathologies, it is very difficult to distinguish from the lung field from the heart borders. In the diaphragm, the right hemidiaphragm is usually higher than the left. In normal X-ray, you can't clearly define the diaphragm from the underlying liver. If you can differentiate the diaphragm from the underlying liver, you should suspect the air under the diaphragm and should ask for the senior help. In normal X-rays, the costopenic angles are acute. You can see the loss of this acute angle in the consolidation or presence of the fluids. Costopenic blunting can also develop due to lung hyperinflation as a result of the diaphragmatic flattening and subsequent loss of the acute angle. In everything else, you need to comment about the mediastinal contours such as aortic knuckle, aortopulmonary window. In bones, you need to check for the fractures and lytic lesions. When you are checked for soft tissues, sometimes you can see the large hematomas. Chest X-ray is also essential in confirming the place of tubes, valves, and pacemakers. So this is the end of today's discussion. We will meet you in our next video. Until then, happy learning.